Good morning, reviewers. My name is Ahmed Irshad and my register number is 154081002. This project was guided by Dr. Velmurugan and it is a retrospective cohort study and it's titled Effects of Aspirin on Cardiovascular System Related Outcomes. So these are the literature reviews that talk about aspirin's effects in cardiovascular protection and its failure in doing so. Some papers say that it has significant reduction and some say that it has no significant reduction in cardiovascular related outcomes and death. Some papers say that evidences were not substantial when compared against placebo. So moving on to aim of the study, it is to investigate the effects of aspirin on cardiovascular outcomes retrospectively. The objective is to evaluate the benefits and risk of aspirin on cardiovascular protection and to assess the number of cardiovascular diseases that are precipitated by aspirin when taken as a supplement or as main therapy. And the last objective is to compare the relationship between the risk factors and aspirin associated CVD outcomes and diseases. So moving on to methodology, it is a retrospective cohort study which will include collection of patient data from case reports from medical records in ESA hospital. So approval from IEC was received for conducting the study. Records date back to 10 years from 2008 to 2018. The data obtained from records include data of patients who were prescribed aspirin either as main therapy or as supplement. The data of those patients that come under the inclusion criteria are collected. The data will be analyzed after segregating the sample cases that were prescribed with aspirin into groups based on presence of cardiovascular diseases or events as group 1 and 2. Further, group 1 will be divided into subgroup A and B based on the presence and absence of risk factors respectively. The group based on the risk factors which are uh, smoking, obesity, hypertension, dyslipidemia and diabetes mellitus, which are risk factors for cardiovascular diseases. Group 1 and 2 must have a sample size of 136 sample cases each. The data will then be analyzed and the rates and outcomes of these CVD might be a direct indicator of heart harm benefit ratio. This will then be calculated and presented in front of the review board along with the thesis. So patient selection, patients who were prescribed with low dose and normal dose aspirin per day with or without risk factors for cardiovascular event were included in the study and patients between the ages of 18 and 60 were involved in the study. So patients with any diagnosed malignancy were excluded and patients who were already previously diagnosed with cardiovascular diseases such as congestive heart failure, atherosclerosis, myocardial infarction and stroke were excluded from the study. Endpoint of the study is the requisite hospital records and for fatal events, death certificates, autopsy reports for all reported cases of myocardial infarction, stroke, and venous thrombosis who were prescribed with aspirin as a supplement or as a long-term therapy. The records were of cases diagnosed and approved by physicians using standardized criteria to confirm or refute reported events. Reviews of endpoints were unaware of the study, so it avoids bias. So reported myocardial infarction was confirmed if its symptoms met WHO criteria and it was associated with elevated levels of plasma enzymes or characteristic ECG changes. Silent MI were not included since they could not be dated accurately. Deaths due to coronary disease were confirmed on the basis of autopsy reports, symptoms, circumstances of death, and history of coronary disease. Reported stroke was confirmed on the basis of medical records showing a neurological deficit of sudden or rapid onset that persisted for more than 24 hours or until death. CT scans were available for more than 90% of the confirmed strokes. Statistical analysis. The collected data was analyzed by using descriptive analysis statistics like mean percentage, relative risk, confidence intervals, and p-value for calculation and making tables and graphs. The obtained data will be statistically analyzed with the help of SPSS software. And this chart depicts the flow of samples and number of samples first we collected was 402, out of which 79 were ineligible samples and were excluded. And the final number arrived after getting consent was 303, out of which 186 fell into group 1 with cardiovascular events and 117 fell into group 2 without cardiovascular events. And group 1 was further divided as aforementioned into subgroup A and subgroup B with CVD and without CVD. Numbers 74 and 112 respectively. So moving on to results, table depicts the baseline characteristics of the same sample population. The patient demographics was very diverse, with most of the aspirin prescribed group being 36 to 50 and older samples. Gender distribution was uneven, with it leaning towards male gender. The number of samples with use of aspirin as main therapy was 87.4%, where rest used it as supplement or day-to-day use or and also as prophylaxis. The use of aspirin based on duration was also considered, with aspirin being used for less than 5 years by 43.6% of the sample population. Also, the sample population had not so significant levels of alcoholics and smokers. This table represents the odds ratio in the incidences of CVD and CVE between group 1 and group 2. Group 1 has 186 samples with CVD and group 2 has 117 samples without CVD. Group 1 had higher chances of precipitation of CVD, as it is the group with more cases of CVD and CVE. This table represents the odds ratio in the incidences of CVD and CVE between group 1 with this table represents the relative risk between incidences of CVD and CVE between subgroup A with risk factors and subgroup B without risk factors. Subgroup A has more risk of myocardial infarction, atherosclerosis, whereas B has more risk of stroke and bleeding. This shows that the drug aspirin has direct effects on the population, causing bleeding and stroke. The figure represents the p-value of incidences of CVD and CVE between subgroup A with risk factors and subgroup B without risk factors. This shows that the group with bleeding has a higher incidence and acceptance levels, and can be inferred that aspirin intake might lead to precipitation of cardiovascular effects like bleeding. This table represents the incidence of cardiovascular diseases and outcomes and events in subgroup A, which had lesser incidence of CVD and CVE. Subgroup A has also been observed to have incidences based on risk factors, and it was found to be 14 cases for myocardial infarction, out of which most cases were obese. And stroke has been seen in 16 in the sample population, out of which 6 were obese and dyslipidemic. 15 experienced bleeding after intake of aspirin, where most had dyslipidemia. Atherosclerosis was precipitated in 26 cases, out of which 9 had dyslipidemia. Mortality was also seen in the sample population, which was one across risk factors like obesity, dyslipidemia, and diabetes mellitus. This figure is a graphical representation of the incidences of cardiovascular diseases and outcomes in both subgroups A and B, where it is seen that subgroup A has higher incidence rates in myocardial infarction and atherosclerosis, whereas subgroup B has higher incidences of stroke and bleeding. Mortality rates were high in subgroup A, though the mortality rates cannot be solely accounted by the prescription of aspirin, as many other factors like age and other risk factors come into play. So moving on to discussion. In this study, the established side effects like bleeding and stroke was high in subgroup B. This was consistent with the recent trial by Broughton C. And in a study conducted by P.S. Shanmuganandam, shows the efficacy of aspirin in primary cardiovascular prevention, but also shows that the drug also increases CVE like bleeding, which is also similar to this study. The study is also similar to a study conducted by D. Baradis. Significant interactions were detected between the magnitude of risk conferred by aspirin. The importance of this study is that it involved risk factors that might have caused these effects, similar to our study. The overall mortality from our study is 5, like the study conducted by Belch with aspirin on diabetes showed that there were more deaths in aspirin group than no aspirin group. In the study, there were 43 deaths from stroke occurred in aspirin groups compared with 35 in no aspirin group. However, the results are contrasting from the results of study by Hansen et al., where the aspirin group had lesser incidence of major cardiovascular events by 15% reduction and all myocardial infarction by 36%, with no effects on stroke. These are the references that I had to go through for the study, and I got the approval from IEC Committee of Vistas, and this is the certificate, and the number is given above. And this is my status on preparation and the presentation of the manuscript, and that's all for the presentation. And I'd like to thank the college and the chairman and the pro chancellor and the vice president and the registrar and the controller of examination and the director and and our HOD for family, Dr. Ashok Kumar sir, and my guide Rame Velmurugan sir. And I want to thank all my friends and parents who supported me. And I'd like to thank everyone who were involved in the study and helped me to go through it and complete it. Thank you. Doubts will be welcome.